Hello, everyone, and welcome to another Facebook Live here with the Epilepsy Foundation. We're excited to be here and have our two guests with us to be talking about a very rare type of epilepsy. So tonight I have with me Lisa Sobi, right? Did I say that right? Okay.
You sure did, Brian. Thank you.
Awesome. So, will you go ahead and please introduce yourself for our audience?
Absolutely. And thank you, Ryan, for this opportunity and to the Epilepsy Foundation for letting us share this important information with you. My name is Lisa Sobi, and I am the co-founder, along with two other moms, of an organization called Hope for Hypothalamic Hamartomas. And it's a long name for what can be a very small tumor, yet very devastating to the individuals that have that brain tumor. So the goal of our organization is to help other families to get the support they need and to also expand and encourage better diagnostic procedures, being able to get kids and adults the help they need, improve treatments, and also to encourage research to better understand this very rare brain tumor and the epilepsy associated with it. I have a 20-year-old son with an HH. Makes it much easier to talk about if we call it an HH. And we have been on quite a long journey from having been misdiagnosed for about 3 months and taking 3 doctors to finally get a correct diagnosis, and then spending years trying to get treatments for what was once a tumor that was thought untreatable.
Wow. Okay. Well, thank you for sharing that, and definitely thank you very much for being here with us tonight. And yes, going forward for tonight, let's try to refer to it as HH because I've tried to say that correctly, and I just don't know if I can, to be perfectly honest. So,
it's definitely a big word.
It's a tough one. Also with us tonight is Dr. Nathan Fountain, who we've done some work with before on videos very similar to this. So we're happy to have you back on these videos, Dr. Fountain. If you wouldn't mind going ahead and introducing yourself to the Facebook.
Yeah, thank you, Ryan. Thank you for that introduction, also for inviting me to come back. It's a real pleasure and an honor to be here. I'm a neurologist at the University of Virginia, where I'm an epileptologist, so a neurologist who studies epilepsy, and that means I care almost exclusively for people with epilepsy, and director of the epilepsy program there. I've done a lot of work with the Epilepsy Foundation, and have a particular interest in hypothalamic hamartomas, in HH, for a lot of reasons, but one really important reason we'll get to later is because we're conducting a study at the University of Virginia of a new technology that we're really excited about that could possibly treat HH in a non-invasive manner.
That's fantastic, and we'll definitely touch on that a little bit later. I want to start off tonight with some basic questions, but we are happy and would love to take questions from the audience. So if you guys have some, we're watching the chat, and we'll try to answer as many as we can here on the screen, as well as responding to you directly into the chat. So thank you, everybody on Facebook, for being here and watching with us tonight. So the title of this chat is When Laughing or Crying is a Seizure. So let's talk about, can a seizure be an episode of laughing or crying? Is this, and it's kind of hard to even put that in my mind where, somebody having a seizure is actually them laughing or them crying. So Lisa, if you could touch on that a little bit, and how exactly does that perceive?
Yes, and it is one of the more baffling parts of this condition, this tumor called the hypothalamic hamartoma. I can probably best describe it in an example with my son. he had his first gelastic seizure literally as he was being delivered in the delivery room. And the doctor that was delivering him said, wow, I've never had a baby try and talk this early before. Isn't that wonderful? And I remember looking at my husband going, you know, the first at anything like that, really, I'm not too sure. But didn't think anything about it. 10 fingers, 10 toes, everything seemed in place, everything was great. But he made this funny kind of grunting, squirming sound about every 3 to 5 minutes. And for this lasted for about 3 months. And he would have kind of a smile, but not really a smile at the end of this little episode every few minutes. So we thought, well, we better have this looked into. Doesn't seem right. Went to 3 doctors, and they said, you know, so sorry for you. It looks like your son has a terrible case of colic. This is just the way it looks for him. And went to 3 doctors, and everybody kind of had the same response. And it wasn't until I said, you know, it's like almost like he smiles at the end, but he's only 3 months old. How can that be? And finally got somebody that had done some recent reading about a gelastic seizure and said, a smile, wait a minute, let me look into that. We ended up getting an MRI, and lo and behold, there was a very large tumor in a very small brain, and we got the diagnosis of an HH, and it ended up he was having between 100 and 300 gelastic seizures a day around the clock.
Oh my goodness.
And we have lots of families that are misdiagnosed, some for years, because these gelastic seizures manifest as a smile or a laughter. And who wants to treat a child for smiling and laughing?
Right.
So it does make the diagnosis extremely challenging.
Okay. Just real quick, it seems like we might be having some issues with audio. Can you guys hear us out there in the audience? Can you give a shout out or hit the love or like button if you're able to hear us okay? Just as a quick audio is can you guys? Okay, so we're getting some that can hear. Maybe Lisa, it seems like maybe you might be coming through quiet. Maybe if you could adjust your mic, just so we can make sure everyone can hear us okay. Sorry about that. Sorry. Nothing ever works correctly with technology these days, I feel like. So sorry about that, guys. How are we sounding? Are we sounding good, Lisa?
Okay, I've turned up the volume there. Does that sound better? I'll try and speak a little louder.
Sounds good. Sounds good.
Okay.
So taking off on that theme, you know, really seizures in general, you might even have to back up because you said, you know, can crying or laughing be a seizure? But, you know, almost anything could be a seizure because seizures, we take a step back, what is a seizure? A seizure is an electrical storm of the brain.
Mm-hmm.
And so the way it manifests depends on which part of the brain's affected. So the easiest one to understand is if someone has electrical storm, a seizure that comes from their primary motor cortex. That's the part of the brain that drives the muscle activity. And so if it comes from that part that, let's say, controls your right hand, then it's going to cause right hand jerking because that's where the electrical storm is. So some places in the brain are easy to understand if they have a seizure there. If it's the primary visual cortex, the part that allows you see funny things, or you might not be able to see anything at all.
Mm-hmm.
If it comes from the memory part, you might have a memory problem. So then you might ask yourself the logical question, where's the laugh center or the cry center in the brain? You know, we typically don't think of there being one, but yet it is characteristic that, as Lisa was saying, seizures characterized by laughing, so gelastic seizures or crying seizures, tend to come from hypothalamic hamartomas or other things in the hypothalamus. So that's kind of a little background to fill in the difference.
Okay. Well, thank you. What do you call then, Dr. Fountain, this type of seizure, where some with HH? I know there are specific classifications of seizures and some different information or reclassifications have come out recently, but just with this type of seizure specifically, where somebody might experience laughing or crying, something like that.
Yeah, the important thing is that we call a laughing seizure a gelastic seizure, and just because it has two important, it relays two important things to you. One is it says they look like they're laughing or something like laughing. And second, as soon as anyone hears, as soon as a neurologist or epilepsy doctor hears a gelastic seizure, they're going to think hypothalamic hamartoma. They don't always necessarily come from there, but that's what they're going to think about. So giving it that name has two important points to it. One is it tells people what you see more or less, and second is it makes them think about the cause of it. Whereas a dyscrastic seizure or crying seizure, we'd almost always call it a crying seizure. So unlike gelastic, which is a term we commonly use, dyscrastic's a little less common. So a crying seizure, we might also think about a hypothalamic hamartoma, but it's also true that crying's more, in one point or another, is more commonly, or is commonly, somewhat commonly, comes along with seizures from other places. And the key is that both of them are focal in onset, that is, they come from one spot in the brain. Even if on EEG, that is recording the brain waves at the same time they're having the episode, you might not be able to tell it's focal, but we know it comes from that focal spot in the brain. So two kinds of focal seizures that are uncommon that are relevant for this diagnosis.
Okay, cool. So then it's safe to say that when somebody's having this type of seizure, that they're not, and they're having it's causing them to laugh or causing them to cry, that they're not necessarily experiencing those feelings. At least if you want to maybe, is that correct? Is that something your son has experienced? He can definitely say for certain that this isn't something that I'm emotionally feeling. It's just a reaction I'm having, let's say.
Absolutely. The way he describes it is he will actually feel it in his gut first, which surprised me when he was of an age and could describe it. When you think of seizure, I thought of a migraine, a headache, something. It's happening in the brain, and so I expected there to be some kind of headache-like response. But for not only my son, but many patients that I've talked to, that it starts as a feeling, kind of an anxious feeling. It's in the gut, something's not quite right, and then it progresses to a laughter, which for probably a large majority of individuals with the gelastic seizures, they don't feel happy. There is a small portion, I would say, and Dr. Fountain probably knows numbers better, but just from all the patients that I've had experience with, probably a third say, it does not feel terrible. There is some kind of feeling of happiness, but for a large majority of patients there, and in my son's case, he was not happy at all. In fact, it would distress him because he had kind of an aura or a feeling that it was coming, and he would feel anxious because it's not something you can control. You can't shut it down. And to have inappropriate laughter as a child growing up, you can be a target of bullying and people saying, "What are you doing? Why are you doing that?" And then, of course, on into adulthood in a job situation, to have a lawyer trying to make a case and break out in laughter, or, those inappropriate situations where it's something you can't control and it's not appropriate at that time. Obviously, that causes a person distress that, oh gosh, here it comes. Sometimes for my son, he would actually run out of the room in order to kind of get away from it. And I did, an interesting patient I spoke to was an airline pilot. Cognitively, she was functioning very well with just gelastic seizures. And she commented that when she was in the cockpit and she was transmitting information, sometimes she would have to make a joke as to why she was laughing and trying to speak on the radio at the same time. Again, awkward situation, but she had no idea she was having gelastic seizures. She had not yet been diagnosed at the time. She was an airline pilot. And she also said that she had that desire to run, and it took everything she had to remain in the cockpit, in control, and talking on the radio. So individuals learn to compensate for those that don't have them as often. They are able to have coping skills that helps them get through, but it does cause anxiety, concern, in most individuals, and mirth or that feeling of joy in a smaller part of the population.
Okay. Now, we did get a question from Facebook. It's from Carrie. So, Carrie, thank you very much for joining us tonight and for your question. And I think this one's going to be best for Dr. Fountain. So let's jump right in. Carrie said, I have HH and my seizures have evolved over the last 18 years. Why might this be?
Well, there's two answers. The short answer is that we don't know. We don't know why things evolve in the way they do. But the more complex answer is that the brain's designed to communicate one nerve cell to another. And the way you establish memories, for instance, is one nerve cell communicates with another, and after it connects along those pathways in an established way, that establishes a memory. So those neurons, those brain cells are now changed. So in a simple sense, you could say that's how you lay down a memory, by changing your brain, changing the wiring. So sometimes for epilepsy, we think about it in the same way, that you change your wiring, and each time you have a seizure, that they change your wiring, and that could evolve over time. In HH in particular, the abnormality itself is not a tumor. It doesn't grow. It's something that's a fixed size. It's there. So there aren't any anatomical or microscopic changes you could see over time that we know about that would make it worse. And so it's kind of a mystery why an HH in particular tends to get progressively worse, or the problem tends to get progressively worse over time, compared to other kinds of epilepsy which tend not to, at least not in the way we're talking about. But you can imagine that the fundamental problem is the hypothalamus is right in the middle of the brain, at the base of the brain. It's sort of the nerve center of the brain, to be paradoxical about it, because of course your whole brain is full of nerve cells. But the center of your brain is the hypothalamus, and that connects to many, many other areas. And in particular, it's important for memory and cognition, for certain kinds of thinking. It's sort of centrally located just to affect that. And so you can imagine, if you have seizures from there over time, that it could affect a lot of areas that then progressively get worse. So that really is different for HH compared to other things, so that we are really vigilant for people with HH to follow them over time. We do formal neuropsychological testing to see how it changes. And we'll talk about treatment later, but you can imagine if you've got it and you start to detect some changes, that's when you might say, boy, I really want to be more aggressive about this than I would otherwise, or pay more attention to it. So the short answer is I don't know. It's also common for things to be cyclical, or come and go in epilepsy. Sometimes get better, sometimes get worse. That's one aspect. But it is true, sometimes in HH, either the seizures evolve and get worse, which is in one way or another, very common. And second, for certain kinds of thinking abilities, for cognition to change over time in some people. And finally, really surprising that parallel to that is for some people their behavior changes over time, and of course that could be really problematic. That could cause a lot of problems for the individual that happens to.
Okay, and so this may have answered one of the next questions that we have from Glenn. And Glenn, thank you for your questions. But Glenn said, I'm waking up with gelastic seizures nightly now, and they are turning into either grand mal or screaming seizures. And Glenn asks, is this common?
It can be. So first of all, I guess we should say we're not giving anyone any medical advice, of course, because we don't really know any individual circumstance. But as a general principle, it's probably most common that seizures from an HH start out as gelastic seizures, and for a keen eye, they can recognize them relatively early. Then, as Lisa was saying, she might want to comment on this as well, that often it goes undiagnosed for a long time. Essentially, everybody I've ever seen went undiagnosed for a long time, not surprisingly, given what we said. So really you have to be looking for it. And what brings it to diagnosis sometimes is when the seizures evolve. So the gelastic seizures, the laughing seizures that might not be such a problem, then turn into other more involved seizures, staring seizures, complex partial seizures, for instance, or seizures with more involvement, which people fiddle with things or unaware, they're zoned out for a while. Or, of course, when they turn to grand mal seizures, that is the generalized tonic-clonic with shaking all over. And that everyone's going to notice that. So by that time, it's certainly going to come to notice. And then really it takes someone who's asking the right questions to see that in backwards through time, or maybe even still, to have gelastic seizures and then go look specifically for the HH. So essentially every time that I've diagnosed, it's been able to go back on previous MRIs, which are pictures of the brain, to see it's been there all along. It just wasn't noticed because, as Lisa was saying, sometimes it's very small despite its big name. So in response to the question is when the seizures start to be more grand mal seizures, particularly at night, that's when we really want people to seek some extra help. And the first place to do that is to see an epilepsy specialist at an epilepsy center. There's lots of ways to access that, but the National Association of Epilepsy Centers, the NAEC, so National Association of Epilepsy Centers, will list member centers throughout the country, which includes almost all, probably not all, but almost all the epilepsy centers in the country. So that'd be the place to start. Go talk not just to a general neurologist, but to an epilepsy specialist. And then maybe even, depending on your circumstances, Lisa might attest to, try to find someone with special interest in HH.
Yeah, I would agree, and I think I would be remiss if I didn't put a plug in for our organization, Hope for Hypothalamic Hamartomas. That is exactly what we do. We work constantly with patients that are sometimes saying, "I think my child or my adult, my husband, has what you have described or I have seen on videos on YouTube. They do something very similar. How can I get a diagnosis or what should I do?" And we have sites on our website that are hospitals that deal on a regular basis with HH, that have neurosurgeons, epileptologists, like Dr. Fountain is saying. We can help put you in touch with specialists to get a correct diagnosis and get the correct treatment.
Awesome, thank you. So I think that's it for questions we have right now. One question that I had that you spoke about with your son earlier, Lisa, is kind of auras. So I know that some people do experience auras or those kind of warning signs of a seizure, and I just wanted to kind of put out a poll in our audience real quick. Do you guys have auras before your seizures? Tell us kind of like what you experience with that, or just let us know by hitting that like button on the video. But it does seem like this is something, and you talked about your son having like a feeling in his gut, like it's coming from his stomach. Is that a common one, or are there multiple? Is it just butterflies, or some people have talked about smelling peanuts before, something like that before a seizure. Are those type of, could the warning signs expand from that, or is it just that stomach?
No, absolutely. I think as with as many seizure types as there are out there, there are many ways that an individual may feel a seizure coming on. An aura can manifest in a lot of ways. I just know that startle, that fear, and that feeling is something that is very common. But there are a lot of other descriptions that I have heard, such as smells or just an uncomfortable feeling. I think is probably the most common thing that we hear. But no, part of, again, what makes this so hard to diagnose is that there is no standard. And as soon as we think we have a nice little box to put the diagnostic procedure into, then we'll walk with that individual that will turn that upside down. So we are constantly learning, and don't discount anything at this point.
Okay.
There's certainly as many ways for seizures to present as there are people with seizures. So it's a bit of a dilemma for the neurologist as well as it is for people. So the people with seizures often have a very difficult time expressing it, which can be frustrating to them. And then at the same time, it can be frustrating for physicians sometimes to figure out what someone is describing. And really, that in and of itself is important. So sometimes we describe it as an ineffable feeling, an indescribable feeling that people tend to associate in their stomach, as Lisa was saying. But they could describe it as lightheadedness, fuzziness, and it's probably because we don't have the words to describe what's going on inside of us. Because normally you don't think about what's happening inside your viscera, inside your body.
I always like to be aware of, what exactly is going on in my brain. I wish it was something we could look on and, know exactly what was happening, be able to describe that. But it's so difficult. You're right.
That is an important point, though, because so sometimes it's the case where we can't decide if there's spells or seizures or not. Because honestly, a lot of people laugh, of course. mostly for reasons you can figure out easily, but occasionally there's not an obvious reason, and you might think it's a seizure, you might not. And the way we figure that out is through video EEG monitoring. So for instance, some
Okay.
people in the audience might right now be saying, my sister's laughing all the time. Well, of course, that's not an issue if she's just a funny person. Or someone else might be saying, you know, my child does some unusual things that have to do with smiling or laughing. So the way we would figure that out is by having someone come in to an epilepsy monitoring unit to do video EEG monitoring to actually capture the episode along with their brainwaves. There's other things too, but that would be often where we'd start if we're not sure whether or not the episode's a seizure. The other thing to say for those who are not aware is that you mentioned earlier that people don't have control over it. And that's exactly true for seizures. They have no volitional control whatsoever, because by electrical storm, I mean literal electrical storms. When you put wires on their head and record their EEG, you can actually see their brain waves going by as an abnormality. Well, normally, hopefully, and then an abnormality when they're having the seizure. And that's different. Some people might think of this as a confused with a psychiatric condition or something else that's not part of seizures. That's kind of an important distinction. That is, they don't have any control over it. You can't just say, stop laughing or stop crying or don't have a seizure. That doesn't have any effect.
Well, we've gotten a.
Dr. Fountain, could I just make one comment? Ryan, and I wanted to say, when you were talking about the EEGs and the video EEGs specifically, I would love if you could kind of expand on why the gelastics don't always show up on a video EEG. That's something that I think can be very confusing for both parents and patients and practitioners. We have been in a situation where we were doing video EEGs with my son when he was just having gelastics and having a large number of them. And we're in the video EEG, and I'm pushing the button every time I see a gelastic because I recognize the gelastic seizure on him. And one of the nurses came out and said, maybe I didn't explain this right, but you only push the button when you see a gelastic seizure happening. And I said, that's what I'm doing. And there was no correlation between what I was seeing and CJ was experiencing that gelastic, and it was not showing on the EEG. And maybe you can explain that a little bit better.
Sure. So that's an important point, and that's part of why I emphasize how important it is to see an epilepsy specialist at an epilepsy center, because it takes more than just casual video EEG. It has to be someone who's experienced in looking at those things and has an interest in those specific things. Often it would be a pediatric epileptologist, so someone who's a specialist in these specific conditions. When seizures cause an electrical storm of the brain, then EEG wires that are placed on the surface usually can detect it. So most people that are having a seizure, we can see the general area of the scalp it's coming from and correlate that with the area of the brain underneath it. But there are a couple of circumstances in which those, even though there's electrical activity in the brain, it's not expressed on the scalp. And one of those is because the hypothalamic hamartoma is deep in the center of the brain, it doesn't reflect on the scalp. Usually, if you catch enough of them, and if they're manifest, usually eventually you'd see something on the scalp. And of course, when they transition to some other kind of seizure, or if they have other kind of seizure types, then you might see that. But initially, you might very well not see it. So I mentioned before that you need the video as well as the EEG, so you can realize the clinical characteristics of it besides or in addition to the EEG characteristics.
Thank you. So we did get a few responses from the poll. A lot of people saying for their gelastic seizures, a sense of feeling of doom almost. Spouses can see them. So others saying that it kind of feels like they're on a roller coaster. You're maybe getting that G-force feeling in the pit of their stomach. So thank you guys for sending back your responses. And just going forward, we do have a couple more questions. Alexandria asked, can HH develop from other forms of epilepsy, or is it a condition from birth?
As far as we know, it's a condition from birth. That is, you're born with the HH in your hypothalamus, and that's why it typically manifests in childhood. I haven't heard of it before at birth. That's pretty remarkable to have one immediately. Typically, we think of it as being in infants, sometimes in toddlers that it has its onset. Now, probably we just didn't recognize it earlier. Lisa and her obstetrician, just astute observers probably. We didn't recognize it earlier on. It also might be that it takes some time for it to develop for some people, so that there are people who don't recognize it or simply don't have it till adulthood, and how they go through their whole life apparently without having any seizures, we don't know, and what happens one day to tip them over to start. But most commonly, by far and away, most commonly, it's in childhood. And the one thing we can say about HH and gelastic seizures is that whatever we say, that's always going to be something in parentheses, right? Because it's just not a uniform entity. If you take a step back, you'd say there aren't very many things cause gelastic seizures. There aren't very many things that cause you to laugh out of the blue. When you look at an MRI, you can almost always identify the abnormality in the hypothalamus because it's a kind of homogeneous, meaning a constant, smooth place that's easy to identify. On the other hand, the gelastic seizures might not get noticed, and someone might not notice them as gelastic seizures, and they might not look carefully at the MRI. So there's a sort of parentheses for everything we say about HH. So you have to kind of take a step back to look at the big picture so you can make sense of it, but then as soon as you do, you have to recognize every individual is different.
Okay. A couple more questions before I want to ask Lisa some questions. Another question that we got, and this one I think would be for you, Dr. Fountain, was, can the brain learn to keep having seizures? So if somebody got a treatment or was on a medication, something like that, to maybe kind of reduce the amount of seizures or hopefully stop seizures, can the brain keep having them regardless of ceasing treatment?
Usually, particularly in a condition like this where the abnormality persists, so it's going to be there until you have some sort of treatment, then the underlying tendency to seizures will persist. So it's not the kind of thing that goes away.
Okay.
There's two questions to that. Is one, does it get progressively worse? And the answer is often yes. Not necessarily, but often yes. And the second is, does it get progressively worse because you're having seizures? Do seizures beget seizures? And this is the source of much debate among epileptologists and people who study epilepsy. And we don't really know. We think it's better not to have seizures than to have seizures, and it's probably true in some circumstance. The seizures themselves rewire things, just as I said before, and set up new circuits that then make you predisposed to yet more seizures. And then in some other circumstances, probably among some kinds of epilepsy, the underlying condition gets worse.
Okay, thank you. Mariella also asked us a question, and Lisa, if you could take this one. So the question is there a specific age for finding the HH tumor? How many MRIs does it take to find one? So just in working with HopeForHH, what generally are you guys seeing with the individuals and the families that you work with?
I have to say, because of the work that's been done to get HH on the radars, basically, of practitioners, I think the average time frame for diagnosis and treatment has literally gone from years down to months. So I think there is great improvement, mostly because of awareness. I remember when my son CJ was first diagnosed, we were told what it was, and we Googled that long word, and there was nothing. There was maybe a couple of papers, and the information was not good. Today, you can go onto PubMed and various sources, and there are hundreds of papers and studies that are being done and research that is being done. And programs like this, the information that is presented at the American Epilepsy Society meeting every year gets to be more and more individuals like Dr. Fountain taking his time to increase awareness, not only with the families, but with other neurologists and neurosurgeons. The time has been reduced to getting a proper diagnosis a huge amount, and we hope to stay on top of that and do more things like this and get that even shorter.
Yeah, we can't give the HH Foundation enough credit for such good work that they've done and continue to do. A lot of foundations do many things, or a few things well, and HH Foundation does a lot of things well. So that's increasing awareness in the scientific community and in the patient community, which is a tough dual role to do. And well, I'd agree with that I think we have reduced overall the time it takes to diagnose it, and that's in parallel with improved MRI sensitivity, so that's helped. Improved awareness of epilepsy to some degree, that's helped. But I suppose the people that we're most concerned with are those that don't get diagnosed for a long time, because there still are a few people like that. Just saw last month someone with an HH who's 59 or 60 years old. So he could have been treated some time ago. He's one who started having seizures in adulthood, but not last year. So with increased recognition, he could have been treated earlier.
So just going forward and kind of getting ready to change topics a little bit, because we do want to start talking really deeply about treatment pretty soon. But I'd really like to get more or the personal perspective from you, Lisa. So I mean, can we just talk about the experience of like treatment with your son, and what led you guys to believe certain treatments were the right thing to do, and the talk us through the journey of your son reaching the point where he's at now.
Certainly. Ours was obviously it's been 20 years, and when CJ was first diagnosed at 3 months old, when we knew it was an HH and had a diagnostic kind of craniotomy, a brain surgery to figure out what it was, because at that time we didn't realize that the medical community didn't have a good feel for a lesion in the hypothalamus, and these were definitely gelastic seizures, so that connection was not made 20 years ago. It took a biopsy for us to figure out that it was an HH, and at 3 months, the doctor at that time basically handed us our son back and said, this is what it is. There is no treatments at all. Nobody will operate because it's too deep in the brain to go and resect or try and remove the tumor. And by the way, medications we know don't work on lesions this deep in the brain. So our suggestion to you is to go find the best group home you can find, because he'll be in a group home by the time he's 5 years old.
Oh my.
And that's what we were told. Fortunately for my husband and I, it was enough to kind of fire us up. And of course, the response was that can't be the answer. Mm-hmm. So we started searching literally around the world and through any kind of medical journals we could find. We joined up with about 5 other families in a small online chat group. And one of the families happened to be an Australian family who had HH and had found a surgeon who practiced through the top of the head of the approach to get to the tumor. And so we all waited patiently to see how that went. And the surgery was extremely successful. Dr. Rosenfeld pioneered what is called the transcolossal approach. It was the first really successful approach used on HH in the early years. But it went the greatest distance. The tumor is basically at the center of the brain. It's hard to do backwards on a video here. Basically at the center of the brain, where all the critical structures, and Dr. Fountain can talk to those, but the hypothalamus, as he said, the CPU of the brain, the pituitary gland, everything, the vision centers go basically straight through that area. So a very dangerous place to operate. It was just not considered the place to go. When we had heard that surgery was successful, the young lady that went in removed the tumor. She was seizure-free immediately from the time she came out of the anesthesia, never had another seizure. So we were excited and went to the surgeons at Barrow Neurological Institute and said, yay, wow, look, here's the approach, can you do this? And even at that time, understandably, the answer was no, we don't do that. It's too deep in the brain, too risky, we're not going to do that. So we contacted Professor Rosenfeld and said, is my son a good candidate? And he looked at the MRI and said, absolutely, I can do this. So it took us a year to get there, because Australian medicine would take 1 international patient a month, and people were flocking from around the world to have this surgery because my son had progressed, as Dr. Fountain had talked about, from gelastic seizures to complex partials to myoclonic jerks. And we were losing him cognitively a little bit every day. He was now 4 and has had 4 years of, you know, these intractable epilepsy. We've tried every medication. We tried 15 different seizure medications in combinations of cocktails of 2 and 3, and my son would throw up the most crazy colors because all of these medications had a different color, and it was, you know, putting it in throughout the day. It was just not a way to live. And so we went to Australia, had the surgery, the transcolossal approach, and CJ was seizure free. So we brought him home and went back to Barrow and said, you know, tell us again why we don't do this surgery. And fortunately for us, the doctors there, Dr. Spetzler and Dr. Rekate, said, you're absolutely right, we need to do this. So they invited Professor Rosenfeld to here to Phoenix, and we were able to get about 7 or 8 patients to come and to be operated here. So now the Barrow has become the center of excellence. CJ, it's about 4 years later, and as Dr. Fountain had said, had been wired to be predisposed to seizures and started seizing again. We were not able to get 100% of the tumor out in Australia. Mm-hmm. And by this time, Dr. Rekate here at Barrow had made the leap to the endoscope. So much less invasive approach, a small tube inserted into the brain, and was able to get another probably 25%. CJ was again seizure free, lasted about 3 or 4 years, began to seize again. And by this time, we went from below again because that was the last piece that we had come in from basically all 4 directions. So at 13 years old, he had a 4th surgery, and knock on wood, today he is almost 20 and he is still seizure free.
That's fantastic.
However, we do have endocrine issues that he will have for life, and he has pretty significant short-term memory loss. As we'll get into when we discuss treatment, the tumor is usually very close to some structures that is where information goes from short-term to long-term memory, and unfortunately sometimes that can be compromised in the surgical process. But we have a kid who's seizure-free and has graduated from high school, and we're working on transitioning him to an independent life, a job, and being an active, productive member of society. So we're very grateful for where this journey has led us to today.
That's really terrific.
It is.
You know, that's a great illustration of the complicated risk-benefit assessments you have to make. You know, surgery always, interventions like this, but particularly surgery, always you have to think about, do you want your risk up front or spread it through your life? You take the risk up front when you have surgery, but hopefully it's going to work out well and you do well, or do you want to spread the risk over your life? And so I think that's a really hard thing for people to do, but it's also the case that they just, I think, have to be persistent, just like you were, regardless of what they're doing, but particularly in that kind of circumstance. So that's a fantastic story on many levels, not the least of which is great that he's seizure-free.
Exactly, a good outcome.
So a lot of different treatments it sounds like you went through, and just kind of echoing Dr. Fountain, absolutely wonderful that he's doing so well. 4 surgeries, that's a lot, but the risk and the reward. So Dr. Fountain, when we talk about therapies, a lot of seizures are treated with medication. Is medication really a viable option for HH in people with gelastic seizures?
It's certainly the first treatment because it's what needs to happen initially to prevent more seizures. It's not as though it doesn't work entirely. There are some people it doesn't work entirely, but for most people there's some benefit, and so you'd rather have some benefit than no benefit. So certainly medications are the place to start. And the kinds of medicines we use and the way we use them is pretty similar to other kinds of epilepsies in general. The key, though, is if you identify an abnormality, a lesion, in this case the HH, and it's something you can fix, then you'd much rather fix it and cure the problem, particularly if seizures persist despite the use of medicine. So if we kind of go back to the principles we use, if you fail 2 seizure medicines and have focal onset seizures, and that's a time we think about, is surgery an option for you to resect, that is, remove the place where the seizures are coming from. It's a general principle for all of focal epilepsy. And just so happens in an HH, they tend not to respond to medicines, although occasionally they might respond sort of minimally adequately. And you can now, today, identify the lesion and then treat it. And whatever kind of treatments we talk about besides medicine, the idea is to remove or ablate the lesion, to somehow kill off the cells that are there, remove them, so you can fix the problem. Because the seizures are coming from the HH. We know that from a number of different kinds of studies, at least initially. And eventually they may be coming from other places, but at least initially, and maybe for a long time, we really don't know if they eventually spread to other areas, although it seems likely in some cases they do. And so that means all the treatments are aimed at that. So medicines are first line, certainly, but if the first 2 medicines don't work, then that's when we start to think about different surgical approaches.
So let's talk about then treatments that are currently available. So we have the type of surgery a little bit riskier that CJ went through. Are there any other surgeries or treatment types that are available?
It's great to look at this historically in a way, because at least at 20 years ago, well, 20 years ago to me is not that long ago, right? I remember 20 years ago easily, and I remember 30 years ago not too long ago either, but it's true that if we go back 30 years, most people would not do anything for this lesion. They would say nothing's going to work, unless it was large and identifiable and you were willing to sort of take the risk. And then if we go back 20 years, so 10 years into the future from then some resective surgeries were started, but they were still very unpopular. Mm-hmm. And then about, I guess we'd say somewhere between 10 and 15, sometimes between 10 and 20 years ago, surgery, particularly because of efforts like Lisa's and some other efforts in Europe, who had a sort of entirely different idea, surgery became more popular. But really the renaissance, you might want to call it, came with other minimally invasive approaches. So what we typically call the invasive approaches means just what you'd think. So it requires just what operating on the brain requires. It requires an incision in the scalp, and it requires removing part of the skull, so making a window. That's a craniotomy. And going through part of the brain to get to the middle of it. So that's sort of traditional way you'd operate on the brain. That's the only way to get there. Then there's minimally invasive approaches, and minimally invasive mean you still have to do something, but it's not so drastic. So minimally invasive approaches typically have to do with putting something like a wire, an electrode or probe, into the brain to get at something. And so for the case of HH, the first thing were the surgeries we talked about, and Lisa talked about some of the ways to access, I've talked about almost all the ways to access the hypothalamus, actually. Top, bottom, sides, front, and back is all you've got. So, and there are specific techniques that are less likely to injure these important areas, because you can imagine it's right in the middle of the brain. It's almost, you must traverse something important no matter how you get there. So it's kind of a problem, and an anatomic problem no matter what you do. With minimally invasive techniques, then, it means you still have to go through those areas of the brain, but it's in a very minimally invasive way. So Lisa mentioned endoscopic surgery. So an endoscope is something that's a flexible tube or fiber optic device that can be tracked anywhere in the body, in this case into the brain, into the ventricles, to identify where the abnormality is, and then it's kind of a suction or scooper on the end of the endoscope to get that part of the brain out you're after. And so that's less invasive, right, than having a whole craniotomy. That's a tiny little hole drilled in the head, and then you, in my view of it, snake this to where it needs to go. The other thing to do that came after that was then thermal ablation. And that means putting a probe into the brain, into just the right spot that you can visualize by MRI and other areas, and then ablating the tissue. And so ablating means damaging the cells in some way, most common way through heat. And it could be a radio frequency probe, or there are other older probes that are used less often now. And that was sort of the next iteration of it. After that, then came gamma knife radiosurgery. But I'm not sure my chronology is exactly accurate. But around this, it sort of more or less, as invasiveness goes, next comes gamma knife radiosurgery. And in this case, what happens is that for treating, let's say, a tumor, so not HH, but a tumor, radiation is applied through a helmet that has an array of ways of directing the radiation to a common point right in the middle of the brain or wherever you're directing it to. In this case, the middle of the brain for an HH, to kill off the cells in the HH through radiation. And that really should be ideal, except that the radiation, as it kills off the cells in the brain, does it pretty focally, but yet there's an area around the abnormality that you have to be very careful about because it gets radiation even though it's not what you intend to radiate. And as Lisa was saying, things like the optic nerves are right next to this area and really important. So it's probably a little bit difficult to deliver radiation to that area, but that's still done sometimes. And then the next level, or next advancement, I'm not sure it's level, but next advancement would be laser treatment. And laser, we think about someone shooting a laser at something, but this isn't exactly what that means. But instead it means a similar kind of idea, a probe or electrode that goes right into the middle of the brain, into the hypothalamus, and then it heats the cells through a laser right at the tip. So it's not exactly shooting out a laser like you'd think about, but instead it's just heating the tissue right at the tip of the laser. And the reason that it seemingly is conceptually anyway, better than some of the other approaches is because you can control that heat very well, both because you can control the laser heat, the amount of energy that's applied, but also because you can do an MRI at the same time to visualize what you're heating and how much you're heating it.
Okay.
And then the last thing is non-invasively, so wouldn't this be ideal? So we're kind of getting less and less invasive. And so the next version is the Star Trek version. On the Star Trek version, somebody goes to the sick bay, they lay down, and they run a scanner across their body, they diagnose it, and they put a helmet on them, and they're cured. So we don't quite have that, but we have almost that, or at least we may, and that's focused ultrasound.
Okay.
So focused ultrasound is like radiation, except instead of getting radiation, you get ultrasound waves. And the ultrasound waves are aimed just like radiation at a single spot in the brain, in this case the HH, and it heats it with a very precise amount of heating, so it has that great control. At the same time, an MRI is done, so the MRI can see what's heating and how much. And that means you can initially just heat it up enough to see where you're going, that you're heating the right thing. And then later on, increase the energy after you see you're in the right spot to kill off that tissue. That's entirely non-invasive. It's a helmet that somebody wears.
That's fantastic. How?
Well, but we don't know if it works.
Oh, we don't. So it's still a theory.
Experimental.
Okay.
Right. So I went from kind of the oldest to the newest, and more or less that goes from most invasive to least invasive. And there are fans of every one of those different techniques. So, for example, as I talked about it, as I got further through the progression, you might have thought, oh, this is just getting better. But it's only in the United States, or at least not in Europe, that you can still have commonly available laser treatment, for instance. So in Europe and most of the world, the open surgery is still most common.
Okay.
Fortunately, in the United States, we have laser and things like that.
Now, for the ultrasound, for the Star Trek treatment, is we'll call it that here today, is the Star Trek treatment. Yeah, what kind of, because this is exciting. It's exciting to me, and I'm sure it's exciting to everybody out there. Time-wise, what do you think we're looking at, like 5 years?
Well, we're conducting a study right now in adults with HH.
Okay.
So right now, people who are 18 years and older who have an HH, who have gelastic seizures or other kind of seizures, who have not already had some kind of surgical resection of the HH, are eligible to participate in a clinical trial that we're doing. And we hope to finish enrollment within a year. And if we're able to do that and demonstrate that it's safe and effective, then it could be available relatively soon after that. It's not the kind of thing that's likely to have a large randomized controlled trial. There aren't likely to be enough people. So if we just demonstrate feasibility and that's safe and effective in a relatively small group of people, then we'll acquire experience over time. And the technology will improve to become even more convenient and better, I think. But first we have to enroll people in the study.
Yeah, and that actually kind of leads me into my next question. For Lisa, being part of HopeForHH, it is Are you guys participating with this study? You know, can people go to, you know, your Facebook or your website and kind of see where this is going, and maybe even look to see if they're in the area or meet the conditions to be part of this trial?
Absolutely. We've been working with Dr. Fountain to try and send him as many potential patients as possible. That's kind of our goal, is to work with any of the new technology, and
Wonderful.
to work with doctors like Dr. Fountain that have this kind of exciting technology and treatment. And we listen to him when he says it is still is something that is in the clinical trial. So he has some parameters for individuals that are good candidates, and we leave that up to him and to the specialists. But we absolutely don't want to make a judgment of what's the best approach for any individual. That's not what we do. Our goal is to provide information and access, and then let the provider and the individual do that risk analysis and decide, you know, what they're willing to take on. But everybody deserves an opportunity to have a choice and to do what is best for that patient, and that's what we're all about.
Fantastic. So we have about 5 minutes left for tonight. So I just want to reach out to the audience and say, you know, let's send in those questions, you know, and let us know what you guys are thinking, comments, questions. So we want to take this last 5 minutes and definitely put it towards you guys for being here, for watching with us. So go ahead and send in those questions. Um, in the meantime, um, is the Facebook page for Hope for HH, which is linked at the top of this post. You just click on the highlighted name to go over there. That's a great place to go to hear about this kind of stuff, about these
Absolutely.
type
And
of
our website
enrollments.
is hopeforhh.org.
Fantastic.
And we have a blog, we have several Facebook pages for families to connect and to share information and support. But between basically, I think the web page and our Facebook page are probably the best place to start. And then we'll work on connecting you with other individuals and providers. Whatever someone needs, we hope to be able to provide that.
Awesome.
I'll bet that your audience is right now, our audience is a mix of people, some people with the established diagnosis of HH or the process of establishing it, all the way to a spectrum of people that are maybe even duly diagnosed with epilepsy or share these things. And I bet you that a lot of those people that don't have HH will share a lot of the same kinds of issues, frustrations.
Yes.
And so it's really great, you know, if they have HH, those resources are fantastic on the Hope for HH page. And then also the Epilepsy Foundation pages would help people that are kind of trying to figure out where they are on the spectrum of things if they don't have HH. And just and also I should say, if anyone's interested to learn more about the study, since you brought it up, the easiest way to do that is just to search, to Google Epilepsy Foundation, Hypothalamic Hamartoma, and focused ultrasound.
That's a
For any
lot.
combination of those things. Well, it is, but if you
Can
just
they
go
put in
to the
just
website,
HH and it'll maybe hopefully find it?
HH won't work, but
Oh,
focused
okay.
ultrasound and almost anything to do with epilepsy will. So the study we're doing is mainly sponsored by the Epilepsy Foundation, which has been fantastic in sponsoring our research, in conjunction with the HH Foundation that's been really helpful in designing things, but also with the Focused Ultrasound Foundation, which is its own unique little entity. UVA is one of the pioneers in focused ultrasound, so we have a close association. You could find it by searching for that too.
Okay.
But the HH pages are a fantastic resource.
Fantastic.
And the HH Foundation.
We did get one question, and I'll just have both of you answer, though I'm sure they'll both be very similar answers. We had a question as is HH hereditary?
So the general answer is no.
Okay. What's the complicated one?
There are certain syndromes in which it can be hereditary, but they aren't simply just an HH, they're combined with other things. So under normal circumstances, it wouldn't be.
And
I just would like to say, I think I think there's a potential to find out that for sure, and that is something that we at HopeForHH are trying to partner with some of the researchers in the genetic community to determine that for fact. And I think there have been some exciting and very interesting initial results that may lead otherwise. So we hope to support that and to take that out to the nth degree and to determine once and for all that either it is or it is not. But I think that's something that is, I know as an organization, plan to fund the research to determine that.
Awesome. And I'm being told by our producers that are helping out in the background and on Facebook that the link to the study, if you'd like to check it out, has been posted in the comments on this video. So go ahead and look there as well. But we're mostly out of time now. Thank you so much, everybody who came and watched with us, and I hope we answered your questions. If you have more questions, do reach out to HopeForHH, and you can also reach out to us at the Epilepsy Foundation via our 24/7 helpline, and the number for them is 800-332-1000. So thank you very much, Lisa. Thank you very much, Dr. Fountain. It was wonderful having you guys on tonight, and I hope that we can bring both of you back, either individually or together, to talk about maybe what's come of the trial, right? And all the wonderful things. Yeah, so I would love to be able to catch up with you guys in maybe 6 months or so and see how we're doing with it. It sounds like a great thing, and I'm really excited to see how it works out. So thank you so much. Any quick parting words from?
I just want to say thank you so much for this opportunity, both Brian for hosting this, the Epilepsy Foundation, and Dr. Fountain for taking your time. Again, awareness is what we're all about, and to have this opportunity, we're such a small, rare community, to have this opportunity is huge for us. So thank you to everyone that it took to pull this all together.
Yes. Yeah, thank you. To echo the same thank you.
Thank you, Dr. Fountain. And for everybody watching from the Epilepsy Foundation page or any other Facebook page, go ahead and check out HopeForHH. Check out their Facebook page, check out their site, check out their Twitter, their Instagram. Follow them, like them, love them. Help us raise the awareness. Help us find the information needed to help make everybody who has HS their lives better, and hopefully soon have a cure for that. So thank you again, everybody, for joining us, and we will see you next time. Take care.
Thank you.
Thanks.